Up, fan base? How y'all doing? Coop here, first time hanging with Dr. Cooper. I really appreciate y'all being there. Um, we do this intermittently. Dr. Cooper's been a little out of action lately, but I'm back in it. 2023. Glad you're here, and I'll figure this fan base thing out pretty soon. All right, Isaac Hayes the third. I got you, brother. All right, what's happening? Okay, Ozita, you got me. Okay, good. Thank you all so much. I appreciate it. So we're just getting started here, and got a few more people popping in. On LinkedIn. So we're live on Facebook, my Facebook page, my Dr. Coop MD page on Facebook, as well as Twitter, LinkedIn, YouTube, Instagram. Glad you all are here. And let's get our comments. See here. There we go. Hey, D, how you doing? Marnita, how you doing? Good to see you all. Just doing a few little shout outs here before we get into the content today. Dr. Lopez, hey, what's up? How are you doing? Good to see you. We'll get together a little later today, hopefully, or maybe tomorrow. We'll see how that goes. See if nobody yet over on fan base. I gotta hook up my fan base audience a little bit better than I'm doing. So apologize for the video. It's not perfect. I'm in my apartment in Kansas City, and I love the background of the city behind me. But in my less than optimal technical ways, I haven't figured out how to make it perfect. So, but thank you all so much for being here. I am really happy to be back with you again in 2023, and looking forward to having this conversation. We're right about 9 o'clock now, so we'll give a few more people a little time to check in with us, and then we'll get to it. Talking about semaglutide today, the new weight loss craze, a new weight loss drug. I mean, it's absolutely going crazy out there. And hey, how you doing, Ern? What's up, cuz? Hope all is well on your end. And just giving a few shout outs right now, but we are talking about semaglutide. Hey, what's up, Doc? Dr. Hodge, Rashawn Hodge over on IG. I see you. Thank you for logging in and supporting the brother. I appreciate that. All right. We got a few more people coming in. TKRD 1981. And thank you for joining. I don't know everybody's handles and stuff, so don't charge it to my head and not my heart. But good morning. Thank you for being here. You are live with hanging with Dr. Cooper. I'm live from my studio in today, the sunny city of Kansas City. Hey, Valerie, how you doing? Good morning. Good to see you. How's it going? Thank you for tuning in to us. So we're going to talk about semaglutide today, and this thing is really, really hot, as you all know, and you probably heard in the news. But I think before we do that, I just want to give you a couple of disclaimers. Number one is I'm not advertising for anybody. Coop has no conflicts of interest. The only conflict of interest I have is that I'm an entrepreneur and a business owner, and we have a weight loss program in our business. And so I'm not ashamed to tell you that. But as a physician, I also don't have any conflicts. I don't work for the company that manufactures this drug commercially. That is Novo Nordisk. I don't work for any hospital. I don't work for any academic center. Coop is a solopreneur, okay? And so I don't have those conflicts. I do have a responsibility as a physician, however, to give you information that I think is important to you or could be important to you or those people around you, those people you love, and also for yourself. So that's why I'm here. I'm continuing my mission and my purpose in life, which is to help people. And I don't care what you think about it, but I know you love it. So that's all good. All right. So, hey, how you doing, Carmen? Good to see you down in Texas. I hope everything's well with you and your family. That's fantastic. Good to see you. Thank you for popping in. Hey, Tracy Woods, I see you. How you doing? Ron Dozier, thank you all for coming in over on LinkedIn. I appreciate that. So you're hanging with Dr. Cooper. We are talking about semaglutide, the new weight loss drug. And I was just giving you all a few disclaimers that I'm not conflicted in any way, except for I own a company that actually has a weight loss program. I do not work for any drug companies, et cetera, et cetera, et cetera. Let's talk a little bit first about obesity. I think it's very, very important to kind of just, what are we talking about here? I mean, there are probably, I think in the United States, the data is there's probably 30 plus million people with diabetes that we know about. Now, I can tell you in my practice as a cardiovascular surgeon that every single day we diagnose someone with diagnose someone with diabetes just based on the fact that when they come to us, their hemoglobin A1C is completely out of whack. And I think the AACE, the Association of Clinical Endocrinologists, and some others probably agree that, hemoglobin A1C being elevated, you're either pre-diabetic or diabetic. So that's the 30 million that we know about. There's probably another, God knows how many millions that are undiagnosed diabetics. And we know that one of the major risk factors for diabetes is overweight and obesity. What's that number? 100 million people. 100 million people in the United States are overweight or obese. What does that mean? A BMI greater than 28 for being overweight, a BMI greater than 30 for being obese, and then the super obese, a BMI of greater than 40. We'll talk a little bit more about that a little bit later. So that's kind of the data when it comes to the, this whole obesity epidemic. And I really want to just say, obesity is probably associated with God knows how many other conditions that we hear about every single day, one of those being cancer. And of course, we know the impact on cholesterol, hypertension, and heart and cardiovascular disease. So we understand the impact of obesity. And one of the things that, and I won't get too far into this right now, but it's interesting as I've watched the debate and watched people talk about this on the news over the last few months. And I've been quiet because I just wanted to kind of see how this thing was going to kind of play itself out. But it's been very interesting to me for my colleagues out there, physicians, and I'm just going to be a little critical here right now to talk about, all you need to do is exercise and eat right. Well, yeah, where has that gotten us? I just asked the question, where has that gotten us? It's gotten us a curve that has shown that the rates of obesity have continued to climb, as well as the rates of diabetes. So yeah, we know that works, and no one would say that you shouldn't have a proper nutrition program or a proper exercise program. But the fact of the matter is, all of that, hey, go, eat right and exercise, this is what it's gotten us. Okay, this is where it's gotten us. All right. And so I applaud the people who are out there working every single day to try to find solutions that are going to make it much more, I guess, if you will, attractive or even practical for us to lose weight and to get to a weight that is acceptable to us, and also the one that is going to influence and help our overall health and reduce our comorbid risk factors, of which there are about 60 or so that are associated with obesity. I'm not going to get into all of those. So obesity, as you all know, it just leads to so many other things. There's so many associated conditions and things that we think about: depression, all kinds of eating disorders. Yes. Sleep apnea is one of those things. And so it's pretty well known that these things can be linked directly back to being overweight and obese. But here's the beautiful thing about it. And here's the thing that I think most people understand and know. And that is this, is that a 5 to 10%, and you just start at 5% because that's what was used in the study, reduction in your overall body weight, a 5% reduction in your body weight is associated with a significant, and I'm not going to get into the minutia of the numbers, but is associated with a very significant reduction in cardiovascular risk factors, as well as, let me get back over here, as well as all of the other associated things that go along with being obesity, all those things I just discussed, all those other comorbid conditions that can, quite frankly, lead to other long-term complications and potentially even death. All right. So that's why it's so important. And that's why your doctors, if they're really in tune to it, will tell you even a 5% reduction in weight in your body weight, getting it as close to ideal as possible is very, 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 very impactful and very, very helpful. Okay. So just think about that in terms of where you are and what you're trying to accomplish if you decide that medications are right for you. Okay. So now that having been said, hey, Gloria, how you doing? Thomas Bill, how you doing? Hey, Phil Perry, how you doing? Thank you for coming in as well. I appreciate my physician colleagues coming in to keep me on track, bring up some issues that perhaps I may not think of or even talk about. Okay, but here's the other thing I want you to know is this is not new. Treating obesity with medications is not a new thing. You all know that phentermine, bupropion, a lot of other medications have been out there for a long time, treating people that have been prescribed to treat people for obesity with varying degrees of success, but overall successful. The question becomes, is that going to be effective for you? Okay. And the question is it also going to be tolerable? Meaning side effects. Are you going to have those side effects related to whatever medication you choose? And then, of course, we know for all my surgeon colleagues, surgery is highly effective. Okay. Depending upon the type of surgery. Okay. Now, I've got some patients out there. I'm sure some people who are tuning in here today who have been down that surgery path. And I hate to tell you this, but you can eat your way out of that wrap. You can eat your way certainly out of that sleeve. Okay. So it's that gastric sleeve for obesity. So surgery is probably one of the most effective ways to lose weight. The question is sustainability and long-term of your long-term ability to sustain that weight loss, and also to avoid the gastrointestinal complications that I would argue are much more impactful with bariatric surgery than they are with medications for weight loss. All right. So I'm gonna pause there. You're hanging with Dr. Cooper. I really appreciate y'all being here. Hey, Ken, how you doing, buddy? Did you get your spiritual lesson in, my friend? You and I are supposed to have a talk about that. I didn't forget. I love you, man. It's all good. But the important thing, you're hanging with Dr. Cooper. Let me just do my little spiel here, just giving a few shout outs. The first lady is joined me, giving me a little wave there. What's up, SKPC from Atlanta? Hey, what's up, Sharita? How you doing? I see you out there. Kamoy, Hal coming in from Florida. Thank you so much for joining us. We appreciate that. And all of you all over here on LinkedIn. Lynn, I see you, Lynn Scroggins. Thank you so much, Gloria. If I didn't mention it, Dr. Phil Perry, thank you all so much for being here. I'm still live over here on Fanbase, but I'm waiting anybody knows about how to do this. I'm trying to support Brother Isaac Hayes' social media platform because I think it makes a whole lot of sense. But anyway, we're talking about semaglutide. Hey, Kraylin, how you doing, homegirl? But also here in KC. So let's talk a little bit about semaglutide and what this drug is. Semaglutide was discovered by the researchers at Novo Nordisk, who probably have the market share, the line share. Hey, Stephanie, how you doing? Of the market when it comes to medications, long-acting medications for type 2 diabetes, which is where these drugs were initially discovered and researched, and what the clinical indication really was for type 2 diabetes. We'll get into that a little bit more here a little bit later. But also now, Novo Nordisk has done the study to look at the efficacy in a little bit higher dose for these medications for treatment of overweight and obesity. All right. So semaglutide is and that was in 2012, and now we've got through all the studies, and we'll talk a little bit about more of what those studies showed and what they mean here in a minute. But semaglutide, in terms of how it works, is what we call a GLP-1 agonist. GLP is a glucagon-like protein, a receptor that's in our gastrointestinal tract, pancreas, and a lot of other places in our body. But it basically mimics the effect of a hormone, peptide, whatever, that we already make, called incretin. Okay, an incretin-like, a glucagon-like peptide. Okay, the net effect of it is, or the thing that seems to be so effective, highly effective in diabetes, it raises insulin levels, okay, reduces glucagon levels, okay, which is the opposite, quite frankly, effect of insulin. But it also helps lower blood sugar, regulate blood sugar, lowers gastric emptying, okay. And so when you think about the side effects of these medications, okay, the vast majority of them, how they work in the gastrointestinal tract. Okay. So In some of the early preliminary, even before human studies. So let's talk a little bit about how that interaction was discovered and sort of what it means for your body. So in some of the preliminary studies in mice, and you probably heard this, they advertise when you hear about these brand name products on television, they say, contraindicated in people with medullary carcinoma of the thyroid, as well as some other types of thyroid cancers. In the studies, all of them, and I've looked and I go back and read these things all the time, even in preparation to come and talk to you guys. There was only 2 people that had less than 0.1%, and they had a papillary thyroid cancer. Okay. And so, what they saw in rats is not necessarily translating in humans. All right. That's number one. Okay. But when you start thinking about how the drug works, and I would imagine evolutionary wise that perhaps, I don't know, millions of years ago, this incretin glucagon-like peptide was probably at a much higher level. Because if you think about it, when we were running around chasing dinosaurs for food, early humans, you weren't eating every day. You couldn't quite, there wasn't any McDonald's. You couldn't run down to the local McDonald's when you got hungry. And so I would imagine physiologically, if somebody could go back and look into the DNA of cavemen, they probably would find that, in fact, this, semaglutide, like our GLP-like agonist that we have, because semaglutide is probably much higher in our bodies because out of a necessity. But neither here nor there. I say that because when I explain this to patients that I treat and we treat in our practice, in our weight loss practice, we talk about the gastrointestinal side effects. So number one, okay, if you take this medicine, you're going to feel full sooner. You're going to your gastric emptying is slowed down. Okay. You kind of feel full earlier, meaning you get earlier satiety, meaning, the whole plate of food you don't need, maybe a quarter of it or half. But then you also will feel full longer. Okay. And therefore you won't eat as much. You won't take in as many calories, and you will lose weight. All right. There's also a very complex feedback mechanism that is poorly understood, but I believe it certainly makes a lot of sense with the brain and your those impulses in your brain that say, okay, I'm hungry. All right. Because one of the things they noticed in these studies is also the cravings go away for food and various types of food. Okay. And so therein lies the sort of way that the medicine works and why you see so many gastrointestinal side effects. All right. Nausea being number one. Okay. Constipation, probably the second one as your body adjusts to it. Okay. Some diarrhea. We've had a couple patients that reported diarrhea, gastroesophageal reflux. Okay. Belching, deglutition, we call that, gas. Okay. You notice all those things, bloating, crampy abdominal pain. Those are some of the things that you see in terms of side effects of the medicine. But the reality of it is less than 5% of people in the studies actually reported any major untoward effects. What are those? And probably the most dangerous one was pancreatitis. All right. It happened in less than 1.1% of people in if you collectively look at all the studies. That can be really, really dangerous. One of the things that's very important with semaglutide, in my personal experience, which I'll hopefully be able to share my screen with you in a while to show you that, is it's very important to avoid dehydration, because I think that certainly, again, from personal experience and from the experience of some of our patients, the fact of the matter is that if you're not hungry, you may not also be thirsty, and therefore you may not drink water. So it's very important to be very, very deliberate in making sure that you stay dehydrated. Okay. Very important. All right. So now let's talk a little bit about some of the things you've heard out there in terms of, I'm going to pause for the calls. You're hanging with Dr. Cooper. I certainly appreciate you all joining in and chiming in on this discussion we're having about this new weight loss drug, semaglutide, highly effective, very well tolerated, but hard to get. All right. Very hard to get. And there's a number of reasons why that is. So the medicines were discovered in 2012, initially for a longer acting treatment for diabetes. And what they noticed in those studies is that people were losing weight. So a good thing to do is ramp up, the dose and see if we can actually push this a little bit. Novo Nordisk did that in a very well designed double-blind placebo-controlled study, meaning you don't know what you're getting. The doctor doesn't know what he's giving you. And here we go. Here it is, that versus a placebo in a 2-to-1 randomization, meaning of the roughly 2,000 people, 2/3 of them got the actual drug, 1/3 got a placebo. And so I'll get into some of that a little bit later. But the fact of the matter is that when they saw this weight loss in type 2 diabetics, they're like, hey, let's do the study and see if this works in non-diabetics. One of the things that I followed very early on when they were doing the studies in the type 2 diabetics was in looking at this weight loss, 5, 6, 7, 8, almost 10 years ago, was would the drug, because they're designed to lower your blood sugar and influence all of the hormonal things that happen to lower your blood sugar, lower your hemoglobin A1, would they cause you to be hypoglycemic if you were not diabetic, meaning having a low blood sugar? That was very important for me, because my concern, I was thinking as I was watching these things evolve over the last 5, 10 years, saying to myself, man, what effect would this have in people who are not diabetic, who don't have high blood sugar, whose hemoglobin A1Cs are essentially normal? And lo and behold, although hypoglycemia, getting a low blood sugar, can occur, it did not occur certainly at the level that I thought, and I don't know what the researchers thought, but the fact of the matter is, I was like, man, this would be great if it doesn't cause hypoglycemia. And certainly it doesn't seem to have an overwhelming impact on development of hypoglycemia in the vast majority of people who are not type 2 diabetics. All right. So that was very, very exciting. All right. And then, of course, watching what was going on with the whole thyroid issue, watching what was going on with the pancreas issue, even, there was some concern about evidence of pancreatic cancer and those kinds of things. Didn't really bear out at all in the studies. It didn't, period. I don't think there was anybody that developed pancreatic cancer that was in this study. Now, there may be some reports out there that I'm not aware of, but that having been said, so you're looking at a drug that was primarily for type 2 diabetics that now has an indication for obesity. That drug is called Wegovy, same exact, from what I know, is the same exact chemical compound, semaglutide. But in a little bit higher dose, has been shown to be highly effective at weight loss at 68 weeks. So that's over a year. And people were losing up to 15% of their body weight, on average about 35 pounds, and now maintaining that out to the most recent study, I think, or follow-up was 104 weeks. Okay. So what is that? That's over 2 years now, sustaining weight loss. And these are people that are in the study. That doesn't include perhaps post-market now, all the people that have been on these medications since the FDA approved it in June of 2021. So that is kind of the data behind why you now have a drug like a semaglutide that's out there on the market for people, specifically for obesity. All right, let's talk about the indications. All right. Now, I know there's been a lot of stuff in the news about this being the celebrity weight loss drug and et cetera, et cetera, et cetera. But here's the data. This is for people who are overweight, BMI greater than 28, who have at least one comorbid condition. Okay. And that condition could be hypertension. It could be pre-diabetic, diabetic, sleep apnea, a number of other, hypertension itself. I mean, I think I said that, cardiovascular disease, all of those things, at least one indication or one other comorbid condition, along with being overweight or obese. All right. So it's very important to think about that when you are considering going on this medication. Have that conversation with your doctor. Okay. And, really get some insight on that. But I will say to you that in people who are overweight and obese, I have seen some very dramatic results. Okay. So that is sort of the basic indication. All right. Now, here's where it gets a little confusing out in the marketplace, because you have a number of trade name drugs. Ozempic, probably the most well recognized. I think Mounjaro, Saxenda, Rybelsus, Januvia, a number of other drugs in this same class of GLP-1 agonists, okay, that are FDA approved, okay, for the treatment of type 2 diabetes. So what it's created is the impact on obesity and overweight has created, quite frankly, a significant demand for those medications as well as Wegovy to treat obesity, okay, because we know they're the same compounds and they have the same effect, okay? But it's created a supply issue or a lack of supply for those people who need it the most, the type 2 diabetics. And, you know, there are a lot of physicians that will prescribe those medications, quote, off label. We use a lot of things in medicine. So I'm not going to get in a debate with anybody, oh, the FDA didn't approve it. Get out of here. I've been in medicine for 35 years. I can tell you right now, there's a whole lot of stuff we do in healthcare that the FDA doesn't approve. All right. And the FDA does not necessarily direct and tell doctors what to do or what to prescribe. Doctors do that based on their training, their clinical experience, their expertise, and their judgment. All right. So, and that's the beauty of American healthcare. We give doctors the ability to help you get better and achieve whatever goal that may be appropriate for you. Okay. So now that having been said, you create this market where, you know, Ozempic and all these other drugs are being used for weight loss, and type 2 diabetics can't get it. And then you got Wegovy over here that is also in short supply. All right. Another big problem here. You heard me say a minute ago that these were the hype out there. These are celebrity drugs. These are drugs for the rich and famous, et cetera, et cetera. And why would they say that? Money. Very expensive. Very expensive. I can give you my own personal experience with having started this last February myself, and just testimonial. During the pandemic, well, just pause for that right now. Coop got up to 267 pounds, 267, hemoglobin A1C of 5.6, 5.7. Most of my physician colleagues, and you should also know that 5.7 is considered pre-diabetic. I started looking at those numbers like, wait a minute, you know, low testosterone, sleep apnea, hypertension, you know, and now here on the verge of becoming a diabetic, a pre-diabetic, really? No. And knowing that runs in my family very, very deeply, didn't want any parts of it. So started out in 21, and said, hey, look, got to put my foot down. Did 15 pounds for all of my eat right and exercise people. Did 15 pounds on my own. That's the most weight I've ever lost outside of being on deployment on active duty when I was in the reserves. Because it's in a controlled environment and eating right, you're exercising, walking everywhere, a little bit easier to do. We don't do that every day here. The hardest 15 pounds I've ever lost in my life. Took me about a year. I got it down to 250. But then I started looking at these numbers toward the end of 21, and I said, you know, am I going to be able to sustain this? You know, keto, Tito, whatever you want to, keto and Tito's, whatever you want to call it. Am I going to be able to sustain this discipline around weight? And the answer to the question is no. I'm just being honest here, ladies and gentlemen. The answer to that was no. Exercising my ass off, got herniated disc in the neck, had shoulder surgery, knee surgery, had shots in my back, shots in my neck. All of these things, just couldn't do it. Not sustainable. Okay. So I'm very thankful that this medication came along, honestly. And so that's my sort of testimony. So 267, now down to about 210, fluctuate from anywhere from 205 up to about 215, 60 pounds plus. Not quite frankly following any strict diet, just trying to eat healthy, and certainly the exercise has been a little bit of a struggle here in the last year because I have a herniated disc in my neck that I've struggled with here since the late fall of 21, which again was right in the middle of me trying to get on this new healthy kick. So I say that just to get that out of the way, but now let's talk about the experience with the cost of the medications. Okay. So I decided to go ahead and pay out of pocket for Wegovy. And the first month I paid was $1,700, and I got good insurance, some of the best insurance at that time, I think, in the country, state-based insurance, state of Kansas, from the time that I was there on faculty. The next month it was 1,600. The next month it was 800. The next month it was 700. The next month it was about 600. So after about 5 months, and that's during the ramp up phase of the medicine. We'll talk a little bit about that here in a minute. Started out at 0.25, 0.5, 1 milligram, 1.7 up to 2.4 milligrams. And ironically, I'm saying to myself, as the dose is getting higher, the cost is getting lower. So the highest price was when you really start out. So I looked at that. A couple of things were in play there. There was February of last year. The deductible hadn't been met. That's number one. Okay. But then it was not approved by the insurance company. And being a physician, I even called them and said, hey, what's up with this? And I got a lot of runaround stuff, as we usually get. But that's what it ended up. Okay. Is I ended up paying out of pocket almost $6,000 to get going on Wegovy. And so I started looking at that and saying, okay, and started looking at what was happening in the marketplace with Ozempic and some of these other ones. Depending on your insurance, using it off label, those other GLP-1 agonists, they may or may not pay for it. I had a couple of people come to me last month who joined our program because they got kicked. The insurance kicked them off of the off-label program, said we're not going to pay for it because you're not type 2 diabetic. They were taking Ozempic, Mounjaro, and some others. And so I said, but this is not attainable for the average person. I mean, you can't. I mean, how come on. And even the people that have money that can't pay for it, they didn't get to have money by spending money and throwing it away. That's not throwing it away, I don't think. Now, don't get me wrong, but still, that's expensive for the vast majority of people. All right. Even if it's not attainable, it's still expensive. Or even if it is attainable, it's still expensive. Okay. And so we started looking around for alternatives. All right. And for our telemedicine business, Primo Health Partners. Okay. And we started looking at compounding options. I know there's a lot of people, doctors out there, oh, you shouldn't do this, you shouldn't do that. Guys, stop it. Give me a break. Come on. Give me a break. All right. Do your background, do your research. Compounding is safe for the same FDA that approves your commercially available drugs approves and has to some extent, okay, evaluate, license, certify compounding pharmacies. Now, is anybody immune to manufacturing mistakes or aberrancies? I can tell you the answer to that question is absolutely not. I have a very good friend who is a chemist who validates studies, okay, who validates studies for all of these drugs that you see for other conditions, antibiotics, breast cancer, paclitaxel. Told me the other day about a drug that they're going through right now. I won't put her name out there, but a drug that's out there right now that she's validating, and you wouldn't believe some of the divergence from protocol and all those other things that occur in the manufacturing of all these other things. So stop it with all of this. Oh, you don't know about the manufacturing. You don't. What do you know about? Okay. So you're hanging with Dr. Cooper, and I'm going to keep it damn sure real. Okay. So that's for all my physician egghead colleagues out there that want to go out here and try to, oh, you should go do this and go do that. We don't know. You don't know anything. So stop it. Just stop it. Enough of that. Okay. I'm done with that. So we compounded the drug. All right. We found a compounding pharmacy that we use in our telemedicine business. Been very happy. I switched over to the compounding. Intermittently, I'll go and buy the Wegovy just to see. And I did that last week, and it cost me $600. Why? Because now it cost me $700 after taxes because the deductible kicked back in. It's a new year. So we're having these really, really challenging issues getting the medication. So if you can find a reputable physician, a reputable program, a reputable compounding pharmacy that you can get this medication, get it. I say that without flinching, period. Get it. Okay? Because it's unbelievable the way that we have allowed this rhetoric and these so-called smart experts to hijack everything. Look where that's gotten us with drug prices in general. Okay, I'm off my bandwagon. I can get back to the business of this. Okay, good. All right, you had me going there for a minute. I just had to say that. But the fact of the matter is, medications are very, very safe. They're very well tolerated. Okay, and at the end of the day, they're effective. People are losing weight. Will there be side effects? Will there be some things that, you'll say, oh man, I'm a little nauseous? Yes, absolutely. Is there any drug that you can take or any foreign substance you put in your body that won't do that, that does not have the propensity or the capability of doing that? And the answer to the question is there's not one out there that I'm aware of that doesn't cause anything. Okay. If it's been studied correctly, it will cause something. All right. So let's talk a little bit about how these medications are dosed. A lot of people have asked me about, the dosing and how does this work? And, there's a ramp up phase. So in the studies, Novo Nordisk started at 0.25, 0.5, 1 milligram, 1.7, and then up to 2.4, which is the maximum dose at 5 months. So they had this sort of weigh-in period, meaning people sort of, I guess you're in sort of not even opt-in. It's kind of like you're watching them very closely as you ramp up the dose, watching for side effects and things like that. And that went up to about 20 weeks and then up to 20 to 68 weeks in the step 1 study. And basically saw that, people lost there was about a 10-pound, let me see, I got to get this right now, 15-pound weight loss in the phase or the 20-week ramp up period. And then another 15 and then 20 pounds in the second part of that study, for a total on average of about 35 pounds, 15 to 17% body weight. That's impressive. Okay, that's really impressive without people being hospitalized, getting sick, and all these other things. That's pretty impressive. And being able to sustain it now out to over 2 years in some of the follow-up studies. Again, with very, very, very low side effect profile. So very well tolerated, okay, even in the long term, okay? But there's a ramp up period, okay? I think 2 things during that ramp up period. One is side effects, see how you're going to tolerate it. But 2, what's going to be the effective dose? What dose? You may not need, like me, 2.4 milligrams per week when I was on the Wegovy, or 2.65 if you look at our compounded product, milligrams per week. Okay, you may not need that. Okay, so I think during that ramp up period, it gives you an opportunity, particularly because the price, even the compounded, is, it ain't dirt cheap. It's certainly probably less than half of what it would be on the of the commercial products, but still not cheap. You're still talking, if you're on max dose, $600 a month. If you're on, less than that, somewhere around $300 a month. But I think that ramp up period gives you an opportunity to see where you're going to have the benefit, where you're going to have the benefit with the least number of side effects. So 2 things that are happening during that period of time. So it may very well be that 75% of the people in our practice are women, and the vast majority of women are somewhere around 1 milligram to 1.5 milligrams per week, and they are meeting their weight loss goals. So let's talk about that a little bit. I think it's very safe to lose somewhere between 1 and 1.5, maybe 1 to 2 pounds per week. Okay. You got to be really careful when you start getting up to that 2 pounds that you're not just losing water and you're doing what? Getting dehydrated. So it's very important to stay hydrated when you're on these medications. We talk about that with our patients frequently, remind them often to make sure you're getting your water in, because in the studies, when they saw side effects or saw some of the worst complications, pancreatitis, kidney failure, liver problems, things like that, the patients tended to be dehydrated. Now, was it the fact that they got nauseated and started throwing up and got dehydrated? Who knows the answer to that question? But the fact of the matter is they did not have enough fluid on board and they were dehydrated. So it's very important to stay hydrated while you are on this medication, or just as a matter of routine. Okay. So that's kind of, sort of the side effect profile and how the medicine works and why it works, et cetera, the cost associated with it. All right. Now, one of the things that I'll often get asked because of this cost issue is, how long am I going to have to be on this? And that's a very good question. Okay. The fact of the matter is obesity is considered a chronic disease now. Thank God. Okay. And I say that because now that puts it into a different category when you start thinking about drug approvals as well as insurance coverage for various conditions related to obesity. All right. And also, when a physician like myself, who's working towards getting certified in board certified in obesity medicine, and others, it helps with our practice because now we can treat people specifically for obesity, and insurance companies will pay for it because it's now considered a chronic condition like high blood pressure, diabetes, and some of the other ones. Now, that having been said, I have watched a couple of these shows for my people over here on IG over the last several weeks on the major news outlets, and having some doctors on there talking about you need to be on this stuff for life. It's a chronic condition. Well, that's true. Okay. But what do you want to do when you develop high blood pressure? You want to get off the medicine. The only thing you've had to be able to help you with that in the past is exercise and eat right? What's that gotten you? Okay. More weight. Okay. A society that's getting heavier and heavier. Okay. So here's my philosophy on this. Okay. Is that I think, quite frankly, that you should be trying to get off of any medicine if you can. I'm not sitting here, and as I told you, I have no conflicts of interest. I don't work for insurance companies. I don't work for drug companies. They would have to pay me a whole hell of a lot of money to get me on some of these little silly consulting things. I don't do that anymore. I don't work for a hospital. I don't work for an academic institution. I don't work for a health system. I work for them in terms of contract work. Love to do that. So if you need a good cardiac surgeon, call me. But the fact of the matter is that I think a good way to look at this is if you're going to use a medication, use it to try to set a new baseline. Use it to try to get yourself into a better overall healthy lifestyle, develop healthy habits. The only way to change anything is develop habits. Okay. Habits that are going to lead to sustainable, involuntary, unconscious kind of behaviors. Okay. And that's tough. It's hard. It's hard to do that. Okay. So what my suggestion is about this is, if you want to go on the medicine that's right for you, talk to your doctor, look at it, whatever. You decide you want to go on it. Okay. Yeah, go on it. Let's start losing that weight. But at the same time, you need to take that time to develop the habits that, again, are going to allow you perhaps to come off the medication and be able to sustain a healthy weight and a healthy lifestyle indefinitely. That would be the ideal goal. Can you do it? Don't know yet. All right. I'm a year in now. And I will tell you every day, every week, when it's time for me to take that shot, I'm thinking, okay, Coop, is it time to back off? Well, here's the data with semaglutide in terms of stopping. You will gain the weight back. You'll gain it back. All of it, no, but in the short period of time that they've been following people who stopped the medicine, they've gained about half of the weight back. Why? I think because they didn't develop the habits. They didn't develop the sustainable habits and lifestyle. So that's going to support maintenance long term. Okay. Maintaining your lifestyle long term. So here's one of the things that I do in our clinic. We don't prescribe any fancy diets. Here's what I ask all of our patients to do. Okay. Download MyFitnessPal. I don't know who makes that app, but that is a great app. So if I would work for MyFitnessPal. Okay. And put all of your data and your numbers in there. It connects with your health data, which is the thing that comes preloaded on your iPhone that you can give to your doctor, that records your heart rate, all kinds of stuff now. There's so much technology. But I've found that MyFitnessPal is probably one of the best apps out there. Put your data in. It'll calculate what your ideal body weight is. It'll calculate based on that what your caloric intake should be on a daily basis. Lower it by 25%. Lower it by 25%. So if it's 2,000 for easy math, lower your total caloric intake 1,750 per day. Okay. Lower it. I think that is absolutely necessary. Why? Because most of us, well, I eat right next. I hear that every single day in my cardiac surgery practice. Oh, I've been eating right. I did everything right. And you're sitting here 300 pounds telling me that you don't, come on, stop it. Stop it. That's not true. And it's not true because your mind is telling you that that's what you want to do. But what's happening here and what's happening here in this gut ain't connecting. You're eating and you're eating excessively. Okay. And you're not exercising. Okay. So let's look ourselves in the mirror and be honest about that. Okay. The app, in my opinion, gives you the ability to easily record your data. You can scan any label now. The database is so extensive. I mean, literally, you could type in there Chick-fil-A Happy Meal or whatever the thing is called, and it will tell you what's in there. Give you all your macros, micros, fat, proteins, carbohydrates. It's all in there. Okay. Even you can now scan your food if you're out to eat and you don't know what you're eating or what's in it. You can scan it, and the app will give you some idea of what's in it. Amazing technology. I saw that about 7-8 years ago when I was in India. I said that's a game changer from a dietary perspective, okay, and monitoring what you eat and things like that. So write it down. I mean, we used to tell patients, take a food journal. It's so hard. But now you got that app in your hand. Everybody's walking around with that cell phone all day, every day. Just click the label, or even you can just go in there and tell it, chicken, Purdue, Tyson, whatever, how did you cook it? Did you fry it? Did you bake it? Did you broil it? And it will tell you it's amazing. But I think it's so important to, at least for a month or two, to record your information. It's called MyFitnessPal. I'll put it in the comments, D. I'm sorry. Yeah, it's called MyFitnessPal. And so very important to do that. Okay. Also, you can put in how much water you're drinking. You can also put in the type of exercises that you're doing. It has all kinds of stuff and give you some estimate of what's going on. Why do you want to do that? Because I think as you're losing weight and you're getting the benefit of using a drug, semaglutide, to lose that weight, okay, and you're feeling all good about yourself, record everything that's going on there. All right. Because what's going to happen is if you decide at some point you want to come off this medicine, all right, and give that a shot, you can go back and look and say, what did I do when I was on the medicine? I have a record of it now. I've recorded it. Can I do this? Can I duplicate what I did on the medicine off the medicine? So download the MyFitnessPal app. Start putting your data in there. Be honest with yourself. Scan those labels. Scan your refrigerator. I did it here in the apartment once when I lost that 15 pounds. That's what really helped me was MyFitnessPal. Scanning everything, all kinds of food packages. It is there. I mean, those little UPC labels have become tremendously valuable, and a lot of information and data. It's all out there. Okay, so I want you to do that, because I want you to be empowered to do this on your own, hopefully at some point. Okay. That's my story. I'm sticking to it. All right. The other thing I would say, I know there's a lot of programs out there. Last thing I'm going to say, and I'm going to give a shout out to our program, give a shout out to a couple of the doctors that have shown interest, that want to come and join our team. Glad to have you. I need you. You can find out more about our program at primohealthpartners.com. You can sign up there. You can get there's an FAQ there on our weight loss page. All these things that I talked about here today are on that page. And then also we have some information on there about, there's some information about our program, but what you get on our program is this. You're going to get me mostly, hopefully very soon, a couple other physicians will be joining me. We don't not only just have a semaglutide, some people can't tolerate it. So there are a lot of other drug-based cocktails out there that one can use for weight loss. All right. And so, so somebody asked about injection. There is an oral form of the medication, and I can't remember the name of it right offhand, Pauletta. but there is an oral form of the medication, a pill that you can take, but I'm not as familiar with it, and I'm not sure about the efficacy of it. You can text me later, and I can see if I can get the name for you. But there's a pill form of this. But what we're talking about is injectable. It's a once-a-week injection. Okay, our product is compounded. It's compounded right here in the United States of America by an American pharmacist that I know, who I worked with over 20 years ago at Emory University in Atlanta. So very reputable, made in America. So if y'all have concerns about somebody getting something, we don't do China or any other foreign country to make our product. These are compounded, meaning they are made very specifically for each patient. So we don't have a whole bunch of stuff on the shelf we can pull off and just send you. Lag time is about 2 weeks. It takes 2 weeks to get this medicine just manufactured and made. And it takes, once it's made, we ship it overnight frozen. Okay. And so, and you have to keep it refrigerated, or you can keep it frozen while you are on the medication. I'd love to hear from you. I'll take a few questions if there are any. Let me see if I can scroll up here. Yeah, Pauletta, it is injection. Yeah, that's true, Tracy. A lot of people can get Wegovy at a good price. And if you can get it, great, go for it. I can't beat that insurance backed. We can't beat, quite frankly, any insurance backed product, but we certainly can beat not having insurance, under insurance, or in cases right now where insurance companies won't cover it, or you're being kicked off of the type 2 diabetic medicine. So, so look at it. Check, Tracy, check your deductible, because it's a new year. That hit me, and then that price jumped up like crazy again. I just did it just to check it out, and sure enough, it was $600. So I'll be sticking with my compounded product. So I got that. Okay. Hey, Mel, how you doing? Jewel Adams, thank you so much. I love when my nurses chime in and y'all text me or inbox me if I got something wrong. Chris Sereno, DO, MPH, thank you for chiming in. Thanks for your comments. Steve Ricketts, Michelle Sims, Cuz, how you doing? Parashottam Sharma, how are you? Hubert Humphrey, how you doing? Thank you, Belinda. I think I got most everybody that's over here on my screen on StreamYard. And let me see, did I get most of my people? Chillin' Dot, come on. Yeah, you don't have to do that. You don't have to take medications, obviously. Hey, Dwight, how you doing? Natasha, let me see here. Glow Brooks over there. Frenchie Dollface, my oldest daughter. I see you, girl. OTATL, how you doing, OT? Natasha Makes Teas, how you doing out there? Nikita Candidly, thank you. Thank you for She's So Naya, my granddaughter. Ikra Ajmal, I need to give a couple shout outs. Ikra is my virtual assistant. She's over on Instagram, who sets all this stuff, all those beautiful graphics you see. She does that. She is from Islamabad, Pakistan. She is right now in, I want to say Riyadh, Saudi Arabia, for the Hajj. And if you all are not familiar with the Hajj, you should look that up. It's a tradition in the Islamic religion and faith. Travel safe, Ikra, and thank you so much for all that you do. Dr. Sean, Prettiest Page, how you doing? All right, here we go. Got a lot of folks over here on IG. Thank you all so much for tuning in. The recording will be available. Janae, how you doing? K Love, hey, what's happening? Queen Ajane, thank you all so much. KT Dot, how y'all doing? Thank you so much for chiming in. I appreciate it. The recording will be available on all of these social media sites. I'm still live over here on Fanbase, but I have absolutely 0 viewers. I don't know what that means. That means I don't know anything about Fanbase, but I'm going to figure it out. Again, thank you all so much. Have a fantastic Saturday. I'll be back soon. Don't know when. Not going to announce anything. A lot of questions I've gotten on social media about Commotio Cordis, the football player that got hit in the chest and then went into cardiac arrest. I'll probably talk a little bit about that next month during Heart Month. We'll get into that. I'll be speaking at Microsoft in Atlanta on the 2nd of February. And I think we got I'll be doing another little speaking engagement. That's for the Blacks at Microsoft Atlanta group, for all of those of you that are out here on this podcast today. I look forward to seeing you all live and in person on February the 2nd there at your headquarters in Atlanta. Thank you all so much for tuning in and hanging with Dr. Cooper. I'll be back soon with more provocative content and more great information, I hope. But again, check us out, www.primohealthpartners.com. That's Primo with a Primo Health, HELTH partners.com. We look forward to hearing from you. Also, one last shout out, Cindy, my assistant that's in Atlanta, Cindy Morris. Thank you so much for all you do. She's probably going to be like, wait a minute, Coop, all these people now coming in. We're starting to get more and more hits from the internet, just searching for reputable, personable experts like myself who want to have these conversations with you about weight loss. Thank you so much. Have a fantastic Saturday. Go Chiefs. Let's get it. Bye.